Hello everyone and welcome back to Clinical Pharma Easy. Today, we will be discussing hypertension management according to the NICE guideline. Hypertension is a leading cause of cardiovascular disease, and it is essential to manage it properly to prevent complications. Before initiating treatment, it is necessary to rule out target organ damage, which can be detected through tests such as urine analysis, creatinine, and electrolyte levels, as well as rule out other comorbidities such as diabetes and dyslipidemia. An examination of fundus for the presence of hypertensive retinopathy and an ECG to look for left ventricular hypertrophy are also necessary. For young hypertensive patients, it is important to rule out secondary hypertension, which can be caused by endocrine disease and renal artery stenosis. Now, coming to the management of hypertension, the most important intervention is lifestyle modification, such as a low-sodium diet, regular exercise, and stopping smoking and alcohol intake, which should be advised to all hypertensive patients. For hypertensive patients without type 2 diabetes, who are aged under 55 and not of African origin, step 1 is to start an ACE inhibitor such as losartan or angiotensin II receptor blockers, ARBs, like enalapril. If blood pressure is not controlled, step 2 is to add a calcium channel blocker, CCB, like amlodipine, or a thiazide-like diuretic such as hydrochlorothiazide. For hypertensive patients without type 2 diabetes who are 55 years of age or older, or of African origin, step 1 is to start a CCB. The next step would be to add an ACE inhibitor, an ARB, or a thiazide-like diuretic. For hypertensive patients with type 2 diabetes, step 1 is to start an ACE inhibitor or an ARB. The next step would be to add a CCB or a thiazide-like diuretic. If blood pressure continues to be uncontrolled even after 2 drugs, then from step 3 onwards its common management route for all categories of patient where a drug that acts on renin-angiotensin pathway, calcium channel blocker and thiazide-like diuretic is given together. It is important to note that ACE inhibitors and ARBs should not be given together as they act on the same pathway. Step 4. If blood pressure is still not controlled after following the above steps, it is important to consider seeking expert advice. Low-dose spironolactone can be considered if the blood potassium level is less than 4.5 mmol per liter. Alpha blockers or beta blockers can be considered if the blood potassium level is greater than 4.5 mmol per liter. Alpha blockers like prazosin also treat symptoms of prostatic hyperplasia. It is important to note that alpha blockers, beta blockers, calcium channel blockers, and diuretics can cause orthostatic hypertension, which is a fall in systolic blood pressure over 20 mm or a fall in diastolic pressure over 10 mm on standing. ACE inhibitors, ARBs, and CCBs reduce proteinuria in patients with diabetic nephropathy. However, ACE inhibitors, ARBs, and spironolactone can cause hyperkalemia, especially in patients with chronic renal disease. Thanks for watching. I hope you enjoyed it, and don't forget to like and subscribe for more easy to understand clinical pharmacology videos.